Neurology Quiz number 98. Discuss the etiology, clinical features, and management of Leber's hereditary optic neuropathy or LHON. LHON is a rare mitochondrial disorder primarily affecting young males causing sequential visual loss due to optic nerve degeneration. LHON is associated with mitochondrial DNA point mutations and therefore maternally inherited. In LHON, mitochondrial mutations affect complex 1 subunit genes in the respiratory chain, leading to selective degeneration of the retinal ganglion cells and optic atrophy within a year of disease onset. More than 90% of LHON cases are associated with one of three primary mutations in different NADH dehydrogenase genes located within the mitochondrial DNA, encoding for protein subunits of complex 1 electron transport chain. This figure shows the various layers of the retina, and it is the ganglion cell layer which is selectively affected in LHON. The mutations are ND1, ND4, and ND6. ND4 is the most prevalent, followed by ND6 and ND1. NADH dehydrogenase catalyzes the oxidation of NADH. The electrons donated to complex 1 are used by complex 2 to 5 to generate ATP. The LHON mitochondrial DNA mutation is passed down from mother to all offsprings, but the fathers cannot pass it on. In about 60% of families, there is a history of visual loss in maternal relatives. However, many people with the LHON mutation remain unaffected. Rare cases of de novo occurrence of primary LHON mutation can occur. Here, the figure on the left shows the location of DNA in the cell. DNA is present in the nucleus, in the chromosomes, and this DNA comes from both parents. DNA is also present in the mitochondrion in a much smaller amount and comes only from the mother. The figure on the right shows mitochondrial mutation DNA transmission. The affected mother passes the mutation to all offsprings, whereas the affected father cannot pass it on. This figure shows the electron transport chain in the mitochondria and the three common mutations affecting ND4, ND6, and ND1 subunit genes of complex 1. Clinical features. LHON is one of the most prevalent mitochondrial disorders with a prevalence of 1 in 50,000. It has a strong male preponderance, and the usual age of onset is between 15 to 35 years. The natural course of LHON generally follows a pre-symptomatic phase, an acute phase, and a chronic phase. The duration of each can vary, but in general the timeline is 12 to 24 weeks for the acute phase and a transition to the chronic phase after the initial 6 months. The clinical findings in a patient with LHON in the pre-symptomatic phase include peripapillary telangiectatic vessels or peripapillary microangiopathy and mild zones of disc pseudoedema in which there is retinal nerve fiber layer swelling around the optic disc without leakage of fluorescein angiography. The acute phase is characterized by deterioration of central vision and is usually when patients first present. The subset of macular retinal ganglion cells providing axons for the papillomacular bundle and serving central vision is affected first and preferentially, resulting in visual loss that typically begins painlessly and centrally in one eye. Some patients complain of a sensation of mist or fog obscuring their vision, whereas others note mild central fading of colors. Most patients deteriorate to acuities worse than 20/200. Color vision is affected severely, and pupillary light responses may be relatively preserved. Visual field defects are typically central or sequential scotomas. Fundus examination may show optic disc hyperemia, pseudoedema, vascular tortuosity, or peripapillary telangiectasias. However, it is not uncommon for fundus examination to be normal in 20 to 40% of patients, which can delay the diagnosis. The chronic phase is characterized by optic atrophy, which can develop as soon as 6 weeks from the initial presentation. Patients at this stage reach a plateau of visual deterioration, and their chance for visual recovery is poor. LHON classically causes bilateral sequential visual loss, with the interval between the two eyes varying from weeks up to months or years apart. In more than 90% of patients, the second eye is affected within 1 year. Here, the upper figure on the left shows bilateral optic nerve edema without telangiectatic vessels, while the upper figure on the right shows bilateral optic nerve hyperemia with telangiectatic vessels and microvascular tortuosity. The lower figure on the left shows temporal optic atrophy in both eyes, while the lower figure on the right shows diffuse optic atrophy in both eyes. in a case of LHON. This figure shows Goldman visual field testing in a patient with LHON. In A, there is a central scotoma on the left and an asymptomatic paracentral relative scotoma on the right. In B, there are bilateral central scotomas 6 months later. Investigations: OCT or optical coherence tomography. Increased retinal nerve fiber layer thickness is present in the asymptomatic state that first involves the inferior temporal quadrant and then the superior and nasal quadrants of the disc. 3 months after the onset of visual loss, progressive thinning of the retinal nerve fiber layer ensues, beginning in the inferior temporal quadrant and later spreading to the superior and nasal quadrants. Other tests include testing of visual acuity, color vision, fundus examination, and visual field perimetry. In this figure, the left panel shows an OCT image of a retina in a control patient and LHON. The blue lines outline the retinal nerve fiber layer. In LHON, the retinal nerve fiber layer is very thin. The right panel shows visual fields measured by Goldman perimetry. Treatment: there is no cure for LHON. Idebenone is the only FDA-approved medication for LHON. It is a benzoquinone related to coenzyme Q10, which works as an antioxidant, but can also transport electrons directly to complex 3, bypassing a dysfunctional complex 1. In randomized controlled trials, Idebenone has been associated with improvements in visual acuity in patients with LHON. Gene therapy is a potential future treatment. One method involves transporting messenger RNA from the nucleus to the mitochondria to synthesize ND4 proteins. Patients should be asked to avoid smoking and alcohol consumption. LHON may be associated with other clinical manifestations that include cardiac arrhythmias, peripheral neuropathy, dystonia, and ataxia. Such cases are labeled LHON+. LHON mutation carriers, especially females, have been found to have a greater risk of developing demyelinating disease. Prognosis: the visual prognosis is poor in the majority. Visual impairment is minimal and rare, with patients noticing small islands of vision within their central scotoma.